Hi, this is Dr. Frank with the Church of Rational Truth, fixing my hair at the beginning, like always. Today, we're going to talk a little bit about the indistinctiveness of psychiatric diagnostics. This is a topic I talk a lot about with my patients, and it's something that does come up a lot in psychiatric care. I do about 50% psychiatric care in my clinic. I'm family medicine, so I do see this a lot. And basically, this topic is to talk about how we have a problem in the current culture of psychiatric care in that it is very based on putting things into neat little boxes in terms of your diagnosis. It's basically when you approach something, you need to get a very clear, a very distinct diagnosis for a psychiatric disease, because then that is how you determine what your appropriate management is, or at least that's how you make guidelines for the management of that disease process. This is common in all of medicine. Just about all of medicine works this way. You clearly define your illness, therefore you can make your diagnosis. Getting your diagnosis then leads you to be able to make your treatment based on that diagnosis. How can you treat something if you don't know what the problem is? That is generally the culture of how medicine works with most disease processes. This is mirrored in psychiatric care, but the problem, I would argue, in psychiatric care is the problems there are not very discreetly defined always. Things like diabetes, I can boil that down to a single number or a couple of numbers to define whether that disease exists or does not exist in reality. It's very easy. We go this, you have diabetes. Your blood sugar is this high. Your hemoglobin A1C is this high. Anyone who looks at those numbers will all agree you have that disease. This is very hard or near impossible with psychiatric care because it is not necessarily objective anymore. It is very subjective. I can't put an easy number that is universally true to someone's mania, focus, depression. You can try, but they're all based on something subjective. I can make you put a number from 1 to 10 how depressed you are, but that's not going to be the same between people. That's not going to be the same between providers. That's not going to be the same between different areas in the country. And also, it's not necessarily always going to have the same meaning or the same diagnostic ability. I mean, because not only are those things hard to put down as numbers, they don't always apply easily. Just because a symptom is there does not necessitate that symptom defines that disease, because there is overlap and there are things that are not very clearly defined. Many symptoms in psychiatric care have overlapping symptoms, opposite symptoms, different ways of showing. The one key example I always give, because I've done a lot of child psychiatry, is anxiety and ADHD. I see a lot of children wrongly diagnosed with ADHD who really have anxiety disorders, but they check all the boxes for ADHD. If I was looking for ADHD and I was going to do a grading system or a checklist or a diagnostic survey that asks all the questions of the symptoms, you could check every single one of those off for a child because they have all the ADHD symptoms, even though they don't have ADHD. And this is a common failure of these things, is that a lot of times you can get a false positive on them and you have no good way of double checking or being sure of that. Even with a good conversation or in-depth history taking, you still might get a wrong diagnosis because the symptoms can overlap. The example I give is with anxiety, because if you have a child who is anxious or has gone through PTSD and they're in class, what symptoms are they going to show? They're going to show difficulty focusing because they're worried. They're going to be fidgety because they're anxious. They're going to be always looking around the room, not able to stay on the topic at hand because they're worried and looking and checking the door and watching what the other person is doing and worried about are their friends judging them. And what is it going to look like? Their grades are doing poorly. They can't focus. They don't get their work done. And so what does it look like? It looks just like ADHD. They get diagnosed with ADHD. They get treated for ADHD. They get put on a stimulant medicine, as is standard for the first trial of medicines if you're going to do it for ADHD. And then do they get better? No, they get worse, because now you're not really treating the real problem. But the thing is, the symptoms are all shouting a different diagnosis, even though that's not really the real diagnosis. It's an anxiety disorder that's doing it. And this is common for many psychiatric issues. It can go the opposite with ADHD, where someone has ADHD, but someone thinks they have an anxiety disorder because they're always worried, they're scared all the time, because they're not getting their work done. They can't focus on their work. It doesn't get done. Now they're worried and stressed out, and they're anxious because they're not hitting deadlines. They come in complaining of the anxiety, but the real problem was the ADHD that's causing it. And this can be seen in lots of different psychiatric conditions. The other problem is a lot of these psychiatric conditions aren't always very clear cut. I think most of them are really a spectrum. Uh, Bipolar, it's really a spectrum. Depression, it's a spectrum. Autism, it's a spectrum. They're not necessarily you either have it or you don't. Like this person clearly has this. It's so distinct from everything else. It's more of what level of anxiety do you have, and do you have a level that gets you to the point where it's pathologic? Same with depression. Is it to the point where it's pathologic? Bipolar, everyone has extremes and ups and downs, but at what point is it so much to that extent that you call it a disease process? That is the problem with many of these diagnoses, is that it's really not a very well defined category. It is not, I clearly just have bipolar and it's its own distinct thing. It is more of a spectrum of different symptoms that if you average out 1,000 people, you can see a clear bipolar disorder. But in each individual, it's usually more bits and pieces and parts of it that show up the textbook example of bipolar, but very few people are the actual textbook diagnosis. They more have a flavor of it or symptoms that are somewhat consistent with it, but they don't necessarily have 100%. And they don't necessarily only just have to have one. Many times it's a mixture or partial. Sometimes maybe I have a little ADHD and a little anxiety. Maybe I am kind of bipolar, but also skew more towards depression. There's nothing in the book that says you cannot do that, that you cannot have multiple diagnoses or have multiple things going wrong at the same time. And that's what makes it very hard. And that's what makes it, I would argue, incredibly difficult or impossible to have a cookie cutter or clear cut approach to psychiatric care, because we want there to be very clear and distinct lines between all these diagnoses, and they really probably don't have these clear lines. They probably are this really hazy, at what point are you crossing the line into this diagnosis? And I would push for the culture to move away from this. I think the culture is going more and more, like you see the diagnostic manuals, they care so much about how exactly we're going to diagnose and how we're going to cookie cutter approach this thing. And they're really not caring about the real treatments, how to deal with it, other ways of coping, how to properly diagnose. They care more of how can we make a rubric to try and get everybody into the same grouping, which is really probably not how it works. But we spend so much time caring about the cookie cutter or how to cut things up. We're not really spending the time on proper treatment outcomes or really seeing these things as they probably truly are, which is not nearly as cookie cutter. You know, people are not just a bipolar diagnosis or not just a depression diagnosis. Most people are far more complicated than that. And I think psychiatric care is much more complicated than that. This is probably why people struggle to understand psychiatric care. They want to try to put themselves into a nice little box, and people don't really fit in nice little boxes. This is why stereotypes aren't really true. I would say stereotypes happen because some people have lots of general things that might be similar in a group, but then when you look at a single individual, they don't fit that real cookie cutter. They might have bits and pieces, but a real person is much more complicated than a stereotype. And I would say, I'm making up this as I'm talking, not that this is really well formed, but I would argue that maybe trying to do psychiatric diagnoses is like making a stereotype of a problem. Yeah, you might see a whole lot of commonalities that people are similar that have those issues. But if you look at any single individual, they're not going to fully fit that cookie cutter. They'll have bits and pieces, but they won't really be 100% defined like that. They might have parts that you go, oh yeah, that is really close or similar, or it follows some of the trends. I would say psychiatry is much more about following what trends or things that seem to happen in terms of cause and effect, but not necessarily using that as your end all be all for diagnostics and where you're going to put people in terms of deciding what they have. For my own patients, I'll even tell them, I don't care what your diagnosis is. I still have the same tools available to treat you, whether it's therapy, whether it's a medication, or whether it's something else. They're still all the same options. And honestly, I don't care if I'm picking the right diagnosis. I care much more, am I doing the right treatment? Because if my diagnosis is wrong, but I'm still doing the best treatment, I'm still probably going to have a good outcome versus if I pick the right diagnosis, but I'm doing the wrong treatment for that specific person, well, I'm not doing them any good, and I don't get gold stars for answering the question right. I get gold stars for actually doing what's best for my patient, and that is much more on the treatment side. Um, we could go back, or we could go over for hours and hours about proper treatment of psychiatric diseases, but I would say you really should care more about the real pathology with a single person, the individual pathology, and then what for that specific person is going to be the best treatment, rather than just blindly following rubrics based on diagnostic criteria. It is very complicated. I would say psychiatric care is probably one of the hardest things to do and hardest things to master. There's tons of bias, there's tons of mistakes that are made all the time, and that's okay. We're human, we're not going to be perfect, and medicine is hard for a reason, especially when things are not clear cut. But that would be my take on it. I think we need to see psychiatric care in less clear cut terms. I think we can allow culturally for some vagueness in terms of diagnosis. And I think we need to move away from this paradigm where we try to focus so much on putting someone into a group, trying to label them with a diagnosis and then use that label to determine all their treatment outcomes. I think it's old fashioned. I don't think it fits the model of the pathology well. And I think that there are better ways of approaching it by individualizing and not focusing on trying to put someone neatly into a group. Um, that'll be it. I would talk more about pharmacology and pharmacy for psychiatric care, but I think this lecture would end up getting to like an hour. No one wants to see an hour long video, so I'll leave it at that. Old news: we had the results come in for voting, and the money, the passive income, will go towards the church fund again, so that will add some more money. I think it's at probably with this added income to about $700-ish. That'll keep going up, and eventually, when we get enough to pay for a property or to at least cover a mortgage or a loan on a piece of property, then we'll go ahead and move towards that. But that is probably years down the road. That is it for this lecture. I will talk to you all again next week. And so this is once again Dr. Frank with the Church of Rational Truth signing off. Y'all have a great week, and happy Easter for those who celebrate. Bye-bye.